Good evening. I'm Jeff Spence from the Alumni Relations Office at Thomas Jefferson University, and it's my pleasure to welcome you tonight. In this evening's timely discussion, we'll learn more about the race-ethnic disparities and inequities that exist within healthcare and the effects being made in education, advocacy, and policy to combat them. To lead our program, it's my pleasure to welcome Dr. Neva White. Dr. White is the Executive Director of the Frazier Family Coalition for Stroke Education and Prevention Center for Urban Health at Thomas Jefferson University Hospital. We are grateful for her time tonight. She is also a 2011 graduate of the Jefferson Doctor of Nurse Practice program. Dr. White, take it away.
Thank you, Jeff. And I would like to thank the Jefferson Office of Alumni Relations for this opportunity to speak. Let me share my slides. So as we look at health disparities, we really want to look at differences in health, healthcare, and outcomes. And looking at these differences under a particular lens and looking at the various dimensions. So I'd like to start by sharing an experience one of my friends had. She is in her mid 70s, an African American female, and she was experiencing some discomfort. She has a history of heart disease, and she decided that she wanted to go to the emergency room. And this happened a few years ago. And at first she wasn't that sure about going, but knowing her history and knowing her case, she decided that that was the best thing to do. When she arrived at the emergency room, they did tests, and she suggested to them to do an EKG because she had a history of heart disease. And they did an EKG, they looked over, and they just basically told her, well, looking at your case, we think that, maybe you're tired, you should go home, get some rest, and consider making an appointment with your primary care doctor. What she did was she actually looked over at the EKG and she realized that there was some changes. And she called her cardiologist. Her cardiologist quickly called the provider who was looking at her at the emergency room and suggested to them that they admit her with these changes. Now, interestingly enough, they had no idea that this individual that they were working with was a retired cardiac care, not only a cardiac care nurse, she was actually a nurse manager for many years. And when we look at health disparities, not to say that this particular incident could have happened to anyone, but it shines a particular light when you look at the fact that she's an African American woman. She was in her late 70s, living in a lower socioeconomic neighborhood, and being female and being frail, a little frail. So she kind of checked many of these boxes when we talk about disparities. I think what makes this whole case a little disturbing was the fact that she had spent pretty much her entire life fighting for the rights of others and advocacy for others, and particularly in the area of health and particularly in the area of heart disease and women. So this experience really impacted her in a lot of ways. And it, gave her something to think about. But fortunately, she was able to be her own advocate. So when we think about health equity, we really want to look at the opportunity for each one of us to be healthy. But where we live affects our opportunity, the obstacles and reinforcements that come along with that. So when we look at health disparities and we look at social determinants of health, each of these particular areas play a major role in our health outcomes, our economic stability, our neighborhood and physical environment, our education, access to food, our community and social context, and our ability to even access healthcare systems. So each of these determinants have a significant role in our health outcomes. When we couple that with the obstacles that are reinforced through the categories that we talked about that lead to disparities, it gives us an opportunity to really think about how we look at people and how we look at their care. The American Heart Association recently published a call to action. And this is a very interesting document. I think it's very bold on the case of the American Heart Association. It really looks at structural racism as a fundamental driver of health disparities. And we don't often talk about structural racism in the context of health to this degree. And what they've done in this call to action is they've actually looked at slavery. They looked at the historical context of slavery and the founding implications for the United States of America, and looking at the structure of racism, the post emancipation structures of racism, looking at Jim Crow laws, segregation, redlining, even the justice system. Now, the article isn't limited to the African American experience. However, there is a significant amount of time that's spent in this area. But what's even more important is as we look at all of these issues and how they relate to poor access to healthcare, poor housing, and really looking at systematic reinforcement of that, and looking at poorly funded schools, poor access to capital, and its effects on cardiovascular disease and stroke, and this whole concept of toxic stress. So, what this call to action is really doing is just getting us to look at historical context, look at the ramifications of structural racism. What and how has it influenced our healthcare system today? Now, we know that healthcare in and of itself is not equipped to answer all of these questions. And so, what they have proposed is a strategy that addresses structural racism, not only from the healthcare perspective, but looking at it in a general way. So, looking at advocacy, quality improvement programs, leadership, human resource and business operations, and looking at science. Today, we are struggling. We are still almost 1 year in to our pandemic. And we have to really look at racism and COVID. This was an interesting article that was in the May 2020 edition of the New York Times. And it really focused in on a particular family, one family who was dealing with COVID. And in this situation, this young man who was the son and a brother. At the age of 50 years old, he was living with diabetes. And his sister finally got him to go to get checked out. He was experiencing a cough, and she knew he had diabetes, and she knew he had other comorbidities. And she suggested that he go get checked out. He did go to an urgent care center, but they failed to do a COVID test on him. They did tell him to go home, quarantine, but they did not do a COVID test. He did go home. His symptoms got worse, and he was found dead by his family member 1 week later. So this is very devastating. And we know that in the struggle for equity, we know that communities of color have been hit very hard by the COVID-19 pandemic. And much of this is related to racial disparities and comorbidities that are already existing in this community. So, hypertension, obesity, and diabetes. So, these pre existing conditions have only exacerbated the complications of COVID-19. We have to also take into consideration stigma and bias in healthcare and really look at our experiences and our practices. What are the stereotypes that we work with, that we deal with, that influence our perspective? Prejudice, attitudes, interactions, and discrimination. These are things that are very real and that we need to address. And I believe that if we have real talks about these things, real talks about the way that we feel, the way that we interact, where are our deficits, where are the areas that we need to grow, and what additional experiences do we need to move to a better place. When we look at COVID-19 cases and hospitalizations and death by race and ethnicity, it is clear. It is clear that Black and Brown communities have taken on much of the burden of this condition, particularly in the area of hospitalizations and in the area of death. When we look at COVID testing, COVID vaccinations, we see some of the same conditions: access to testing, mistrust that's associated not only with the testing, but also with the vaccine, whether or not a person has health insurance, whether they have a medical home, what outreach is being done, transportation, and the digital divide. And if we think about it, right now, one of the only ways that you can sign up for a COVID vaccine is online. You can try to call some sites, but many sites require that you register online. And for people who don't have access to the internet, that is a clear barrier. So what can we do? We can begin by looking upstream. What are the social inequities that influence upstream so that we can then be able to influence downstream? But upstream is challenging. Upstream, you have to be courageous. You have to be willing sometimes to stand alone or stand with very few. When we consider upstream, we have to look at class, race and ethnicity, look at immigration status, gender identity, and sexual orientation. We have to look at institutional inequities in corporations and in businesses, in government, health policy, schools. We have to look at living conditions, people's physical environment, their social environment, their economic and work environment, and then, of course, their service environment. And then what are the risk behaviors, the disease and injury that are the downstream outcomes? But starting upstream is where we can have our greatest impact and where we can see the greatest good. So I wanted to talk a little bit about an initiative that we're actually doing in the North Philadelphia area. So we have received a generous donation from Andrea and Ken Frazier. And we have created the Frazier Family Coalition for Stroke Education and Prevention. This is a partnership between Jefferson Health and Temple Health. And we are looking at the Allegheny West community, which includes Scarsdale Stanton, the Strawberry Mansion community, and Nicetown, Tioga. This community is actually the community where Mr. Ken Frazier was born and raised. He is giving back to this community. And we want to make sure that his efforts are well thought out, and the work that we do is well thought out. So when we look at this community, we see the influences of stroke, and we see that in this particular community, there's 35 times the amount of stroke, the national average. We also see that when we look at Philadelphia and the percentage of diabetes, high cholesterol, hypertension, obesity, smoking, and stroke in this particular neighborhood, the numbers are significantly high. So the objective of the Frazier Family Coalition for Stroke Education and Prevention is really to create a wholly integrated health education and community navigation system that connects at-risk members, the community with information, resources, and clinical care. What we want to do is we want to create an innovative opportunity to go into the community, working with the community voice, working with two major health systems to fill the gaps of this community, taking on a healing-centered approach to care. And through a healing-centered approach to care, we consider everything that a person brings to their particular situation and utilize all of their history, all of their experience, and where they find themselves as an asset to their care. And looking at opportunities for individuals to create self-management strategies around their hypertension, diabetes prevention, in an effort to reduce the amount of stroke in this community. We have created core tenets that we're going to be looking at. We want to look at analytics. We need to know about the community. We need to collect data because we know that the science in many of these communities that are supporting some of the causes of inequity are missing. So we want to make sure that we're not only assessing, but we're taking that information, we're implementing that into the work that we're doing. We want to have a pretty strong awareness campaign so that people will understand, first of all, what is stroke and what are the components and what is their risk of stroke. We also want to have a general campaign that talks about health and health from a well-rounded perspective. Then we were going to have various health education programming. We'll be looking at social determinant support. We want to be a major referral pipeline. And again, using all of this information and ongoing assessment to inform the work that we are doing. We have created a community advisory group, and this community advisory group is made up of community stakeholders. It is intentional that we want to get people from all different perspectives. We want to have law enforcement represented. We want to have the business community represented, government, education, as many community stakeholders as possible to inform us of the history of that community, the voice of the community, the messages that are important to the community, and how we reach the community. What are the true needs of the community, and how will people respond to the work that we're doing? So we have created this community advisory group because we feel that it's the only way that we can really get to the heart of what this community needs and what they want, and so that the community can actually be heard. So our goal is really to look at health equity, but we have to design it. We have to design health equity. We have to have intentional efforts. And one of the things that we want to do, particularly at the Frazier Family Coalition, is we want to really redesign the culture of health so that we can have access for as many people as possible, utilizing the work that's being done at Jefferson Health and Temple Health. We feel that we have the resources to reach this community. We want to close the digital divide. We know that there are many people who cannot access telehealth at this time, who need to access telehealth. Most of our program, at least in the beginning, will be remote. So we have to really look at how to get people connected to the internet, either by providing them or finding ways to support them with that service or devices, because we have to also think about people needing the device as well as the service. Access to education, which we feel is one of the major building blocks. And then health literacy, because we know that many times people struggle with health information and how to apply it directly to their lives. We want to help people ask the right questions. And this is important because many times when people come to us with their health concerns and with their needs, sometimes there's a lot of fear attached to it. Sometimes there could even be anger. Sometimes there could be mistrust. So helping people to design the kinds of questions and ask the kinds of questions that we can then begin to answer those questions and present recommendations for solving some of the problems that people are dealing with on an everyday basis. We want community participation. And more importantly, we want the community voice to be represented in our work. We want to make the invisible visible. And those individuals who feel that they aren't being considered and their way of life may not necessarily be considered when we look at programming and we look at opportunities. Living wages, we know that people need to have a living wage. And what advocacy work can we do in that area? We need to look at community safety and have a relationship with law enforcement because there's issues on both sides that need to be heard, and having a relationship with law enforcement and really looking at violence as a public health issue and what are some of the contributing factors to violence and some of the factors that really stain a community and put a lot of fear in those that live in that community. Looking at food insecurity and what opportunities are there, not just to provide people with food, but as we say, to teach people how to fish, because we want to create sustainable work. We also want to look at housing and opportunities to work with individuals who are in transition and organizations that work with individuals in transition. And then looking at transportation and what opportunities there are to consider all of these things. So in looking at the work that we do and will be doing at the coalition, it's one step. And we hope that it would be an innovative opportunity, again, to bring two major health systems together and look at how we can create a new way or an enhanced way of looking at the work that we do and really reaching people where they are and getting to the heart of what people feel is really their major issues. So what I thought I would do is end with a reflection. So one of our physicians in family medicine, Chris Foster, and many of her colleagues who are also family physicians and frontline caregivers put together this piece in the Annals of Family Medicine, January, February edition 2021. And it's really a very courageous document. There's a lot of transparency and true hard facts that are in this document, but it also is an opportunity just for us to have a conversation about some of the things that we're experiencing as as a nation. And I thought I'd go to the end of the piece where it says, so what can those of you who want to serve as allies do? And there's two bullet points that stood out to me. The first one is apply an anti-racist equity lens to every decision you make and seek out structured tools to help you do this consistently and with accountability. And then use your privilege to advocate for systematic changes in our society to truly address anti-Black racism and systemic racism, as well as social determinants of health. So again, another call to action that we can consider, and that those of us who are seeking ways to reduce inequity and to provide the best level of care that we can. What I'm hoping that comes out of this pandemic and the lessons that we've learned is that we gain a greater allegiance to humanity and that we really think about what it means to be world citizens and to understand that what happens in one part of the globe eventually will impact all of us. And so it is our world citizenship that we want to really enhance and what it means to be a part of the human race with compassion and care for everyone. So I thank you all for listening and being a part of tonight's talk. And at this time, I think that we can look at some things in the chat.
Yes, thank you so much, Dr. White. We can now open up the conversation with our attendees. If you have any questions for Dr. White, please use the Q&A button located at the bottom of your screen, and you can type your questions there. We also received a number of questions in advance, so we'll be trying to get to those as time allows. So to kick things off, and really it relates to the closing piece that you shared from Dr. Foster. When we're thinking about anti-racism education, what are your thoughts on how healthcare education and educating practitioners can be improved so that new practitioners are equipped to be anti-racist?
Well, I think that going back to the golden rule of treating others the way you would like to be treated is a good starting point. But I like to say, treat other people the way you treat someone you love. Because the way we treat people that we love, if we could treat others in the same way, I think that we would be thoughtful of their feelings and their response to our actions. We can't all be 100% all of the time, but if we can look at each other in a way that we could almost see ourselves, that may guide our actions a little better.
Absolutely. And then you talked a little bit about this in your talk, especially when related to COVID and vaccine distribution and mistrust. How do you foresee the work of the center or even physicians being able to address families who have sort of culturally influenced resistance towards just preventative treatment?
Well, I think that when we talk to people, sometimes we have to understand the origins of their fear and their mistrust and their experiences. Many times people have had experiences that have left them. For example, my friend that I talked about, her years of experience in working in, cardiac intensive care, and for her to be treated that way, she really felt that it was, all of the disparities that were associated with her. She saw that as a direct relationship to how she was treated. So I think if we could get to the underlying fears that people have experienced and some of the trauma maybe they have experienced with healthcare, and really begin to help them to advocate for themselves and ask the right questions and get information and get to the facts. I think that's one way that we can influence people to make that step or make that move to seek out certain opportunities. And especially if we make those opportunities available to people.
Wonderful.
Mhm.
Our next question refers to that many residents in the community that you serve in North Philadelphia belong to a community of faith. Do you think that there's a role that faith-based organizations could do to educate and encourage those communities in your efforts?
Definitely. As a matter of fact, we've started a health ministry forum, monthly forum, where we're talking to faith leaders in the community and really getting from them what their needs are, particularly now when the congregation isn't as engaged as it was pre COVID and reaching people who are isolated and people who are feeling that they need additional resources. So we have engaged the health community, the health ministry community and communities of faith. And this is really an area that we're working with. And we've always done that through our work at Jefferson, through the Center for Urban Health. We've always worked with communities of faith because we see them as there's a group there, a targeted group, and many opportunities.
Excellent. Thank you for sharing that. We have another question um, related to really some of the data and the trends out there related to maternal newborn health outcomes, specifically in the Black and the African American communities. Are you aware of other countries, other areas, other approaches that have really started to have a positive impact on those outcomes?
Well, I think one thing that we have started is the community health worker. And many countries, it could be like a peer, they may call it something different, but sort of a peer to peer kind of reach. I think the role of the community health worker is a significant one. And you may also call them community outreach workers. At Jefferson, we call them community health workers. And we're finding and working with people and training people who are living in certain communities or have the experience of certain communities or even have the experience of some medical conditions, who are willing to work with individuals who have similar um, issues and similar experiences. So it's not necessarily a lay individual, but a lay individual who's been trained, who is a member of the community or familiar with the community, and who can really be a liaison between what's happening in the community and what's happening at the health center.
I apologize, I was muted.
That's okay.
Another question about the work at the center and what you're embarking on relates to the scope of your work. Asking if you're limited to stroke work, or if you might expand into other chronic conditions, especially osteoarthritis and other chronic issues like that.
Well, our overarching goal again is to prevent stroke, but we know when we think about all of the comorbidities that go along with stroke, hypertension, diabetes, all of these things. And we also want to look at lifestyle modifications. So we'll be doing physical activity. We'll be doing a heavy opportunity to look at nutrition. And we're hoping that eventually we can expand the work to include any chronic medical condition where people find that it's getting in the way of what they need to do. We also plan to spend a lot of time talking about chronic pain and doing some work with chronic pain self-management.
Excellent. Thank you. Um, our next question may not relate as much to the work of the center, but in health disparities in general. In addition to cultural and racial disparity, do you see any similarities or differences amongst other minority populations, for example, the LGBTQ community, when it comes to some of the disparities that are in health systems?
Well, again, when we look at health disparities and we look at the dimensions, certainly gender identity, sexual orientation are all part of that. And just as we were talking earlier, so many people have multiple dimensions that they're living with. They're not only living with issues around sexual orientation, they're also living with age issues, they're living with um, where their location. We talked about your zip code being a major contributor actually to your life expectancy. So it's just another dimension that we need to think about when we look at disparities and we look at inequity. So, the dimensions are many. And for many of us, we can almost check every box when we think about those categories and those areas. So again, it gets back to treating each other, with that basic, getting back to our basic humanity. And I think this pandemic has really taught us that we are global citizens. And how do we get to our basic humanity? How do we get back to what it means to be human and extending ourselves with that lens?
Absolutely, it's well said. I think we have just another question that's come in that's asking
Mhm.
about your thoughts on federally qualified healthcare centers. Do you think that there's a need for expansion of such federal programs to help the communities?
I think any opportunities for us to get care, for people to get care, federally qualified health centers is one very good approach. And if we could have more, and that means we could provide more services to people. So yes.
Another question I think relates to the work again at the center. And do you think that will the center have physicians of color that will, or physicians that better represent the community? Do you see it being a sort of diverse workforce?
Yeah, so again, our work is going to be primarily focusing in on we are positioning ourselves to be to support the clinical practice. We are not going to be a per se clinical practice, but to support the work of the clinical practice. And it is our goal to have as a diverse workforce as we possibly can. Again, we are harnessing two major health systems. So we're partnering with Temple Health as well as Jefferson Health. And so that in and of itself will expose us um, to a diverse group of people. So our goal is to reach that community and to be as inclusive as possible in that work.
Wonderful and excellent. And Dr. White, thank you so much for sharing this important and timely work that you and your colleagues are doing at the center. We want to thank everybody who's joined us this evening and participated in the discussion. I'd like to invite you all to remain connected with your fellow Jefferson, Textile, and Philadelphia University alumni by registering your profile on our brand new Jefferson Alumni Network. In it, you will be able to use our online alumni directory to find and connect with alumni based on their name, class year, region, medical specialty, and more. You can sign up today at alumninetwork.jefferson.edu. In addition, we have a number of great virtual programs coming up, including a talk by Provost Mark Tikachinsky this coming Thursday, providing a state of the university. And next week, we invite any of our occupational therapy alumni to join us on Monday evening as we kick off a brand new volunteer opportunity with our OT Alumni Network. On Tuesday, the Jefferson College of Nursing will celebrate Black History Month, offering a continuing nursing education program from bystander to upstander, the Allies Journey. And then our Workout Wednesday series continues on Wednesday as we do a resistance band workout. You can find these and all of our events at jefferson.edu/alumni events. Thank you all for joining us. Thank you again, Dr. White.
Thank
Everyone,
you.
be safe and have a wonderful evening.
Thank you.